Hi guys, today is short and sweet. We're going to talk about the clavicle, AC joints, and the SC joints, acromioclavicular and sternoclavicular. They're pretty straightforward, so not a whole lot to worry about here. Here's the shoulder girdle once again. It is comprised of the scapula and the clavicle. I know that was on the last quiz. The proximal humerus is not considered part of the girdle, but it is evaluated as part of the shoulder. The clavicle and its medial and lateral articulations is what we're going to be looking at this week. So here is the clavicle bony anatomy that you're going to have to know when I come out for the site visits. The image in the book was pretty limited, so I found this other one that has probably a little more than we need to know, but you need to know the sternal or medial end, the acromial or lateral end, the conoid tubercle. That one is not listed on, oh, here it is, conoid tubercle, and the shaft. Those are pretty much the only things I'm going to ask you about. The other stuff is too small of detail. You're not going to see it on the images. General guidelines are the same as the shoulder. Your clothing and jewelry off from the waist up off. So shield all your patients as well. Clavicle. Routine clavicle is AP and AP axial. You could do it PA, but most of the time it's done AP. So the top view is a perpendicular central ray, and the bottom picture is the axial. So your degree of angulation is going to be 10 to 20 degrees cephalad, depending on your patient's body habitus. So if you have a thinner patient, it's going to be a little bit more steep of an angle, and a heavier patient, more shallow angle. So Merrill says 15 to 30 degrees. Typically, it's more like 10 to 20. I think that's what Jeff says. So just keep that in mind. What the book says and what is actually happening out at the sites is always something a little bit different. Here is your anatomy on your images. You can see the one at the top shows the conoid tubercle, which tells me that that is the axial view. That's not typically seen. You can see here on the straight AP view, it's not typically seen. Another clue that it's axial is look at the shoulder in relation to the scapula. It's superimposed kind of strangely, so that's another clue that it's an axial view in case it's not marked as such. Sometimes when I'm out at the clinics, I notice that the medial portion of the clavicle is not always penetrated very well, so you can't always see the whole bone. So the better technique you can use, the better it'll be for seeing the whole clavicle. So if you want to show me something that you're evaluating for a competency, be sure you can see through the medial part of the clavicle as well as the lateral end. AP/AC joints, you typically need to do these standing up, but Jeff had a great picture on his PowerPoint that showed how you could do it if you have to do it with the patient laying down. It's creative, but I would guess that it would work pretty well. So you need a 14 by 17. You need to include both AC joints, and they are always, always, always done with and without weights. There's no other way to do them. You wouldn't just do one view by itself without the other, because the radiologist needs to compare the joint spaces. How you hold the weights is really important. Right down here you can see how he's holding his weights. They're more wrapped around the wrist rather than the patient holding them in their fists, because that activates their shoulder muscles, which sometimes will the muscles contract, and they a lot of times will hold a dislocation in place or a separation in place, and you wouldn't be able to tell if it was separated. So it's better to have the weights wrapped around the wrist, so it's just pulling the shoulders down rather than holding the weights in your hands in a grip. So what you want to see is good collimation. Your collimation is going to be 17 inches wide. You want to include the whole width, both AC joints on one view. and you want to increase your distance to 72 inches if you're doing both AC joints, because they won't typically fit if you're at 40 inches. So 72 inches distance to include both. If you still can't include both, then you need to do 10 by 12s of each individual AC joint, so the radiologist can put them up together and compare them. So you don't want the patient to move in between. You've got to make sure that they stay in position and don't move in between. And this is what your AC joint separation will look like. You can see here how the acromial end of the clavicle is right up against the acromion, and this one is not where it should be. It's separated there. All right. Jeff and Jocelyn will show you how to use the weights so you can avoid that shoulder muscle tensing. All right, SC joints are a little tougher. You have to do these PA, whether on the table or using an upright bucky, depending on your patient. And you also do some oblique views. And you can either rotate the patient's body or you can rotate the angle of the tube. And there's an extra view called the serendipity view that Jeff had in his PowerPoint, and it's not in your Merrill's book, but I'll show it to you briefly so you know what it is and what you need to do that view. All right, so 40-inch distance, you can do this upright or prone. You center at about T3 between the clavicle heads. Jeff says your collimation is a 3 by 5. Merrill says 6 by 8. So just do your best, and you just want to be sure you include both sides. And in Merrill's, it says you can do a unilateral by turning the head toward the affected side, but typically if you're doing the sternoclavicular joints, you're going to do both of them. It's not a huge area. You're going to pretty much get both of them in there. And this is what they look like. See, there's no difference between the bilateral and the unilateral except for a slight rotation of the spinous processes of the thoracic vertebrae up there. Looks like 1, 2, 3 right up in there. All right, and here is the 2 different ways that you can do the oblique views. According to Jeff, your angles should be about 5 to 10 degrees for the joint that's closest to the IR, or you can roll your patient 10 to 15 degrees if you want to take an image of the joint farthest from the IR. Just be sure to include both joints in case your angle is a little bit off. So this view seems to me more like the sternum view, where you see both SC joints at the manubrium. So if you look on page 458 in the book, you can see both joints of the sternum offset from the spine. So we'll take a look at that next time when we're doing ribs and sternum. But this sounds easier to visualize than these descriptions from the book. So just remember, you got to think about what your national exam is going to say compared to what you actually do in the clinic. All right, so these are what the either a PA oblique angling the tube on this one, or a PA oblique angling the patient here. And they look just a little bit different on the images, but not a whole lot. So use your best judgment. I would guess that it's probably easier as far as moving the tube around just to rotate the patient. And I think that's probably, you can ask Jeff and Jocelyn how they would normally do that. But I can count on one hand how many times I've seen sternoclavicular joints. So may or may not even ever see them. But talk to Jeff and Jocelyn and see how they would normally do them. But this is what's in your book, maybe on the national exam. This is the serendipity view of the SC joints, or for the clavicles, and it's basically a like an apical lordotic view, but the patient is typically supine on the table. So, and there's no leaning back for the patient to be unstable if you're standing. Let's see. So typically they're going to do SC joints on a CT scan. That's really the best way to visualize them for dislocations. most of the dislocations for the SE joints happen as sports injuries or car accidents, things like that. All right, so your patient is supine. You have your collimation very similar to the AC joints. So, 6 inches wide and 17 inches long. The width of the crosswise 14 by 17 image receptor. So you use a 40-degree cephalad angle and increase your distance, center at the manubrium or maybe at the jugular notch. That seems like it would be just about right. But you can see down here on the image how it really sends those SC joints up so you can see through there. Also a really good view of the clavicles. So, and once again, this is, you can see the apices really well here. So it's similar to the apical lordotic view of the chest, but you're angling the tube and the patient isn't leaning back precariously. So it's a little bit easier for the patient to manage. All right, and like I said, short and sweet. That's all I've got for this. And just remember, it's almost time for spring break. You just have another week or so. So keep your chin up. You guys are doing great, and I will see you at the clinics soon.